Good morning. Today I'm going to tell you something about the side effects, systemic drugs side effects on the eye. Is a common question that can be asked for examinations, mainly for the postgraduates. I'll tell you a few points about that. Again, I'm stressing this today's topic is ocular side effects of systemic drugs. Now, whenever the patient comes to us, you must always think complaints you are supposed to elicit from the patient. But the common complaints, what now, as far as ophthalmology is concerned, visual problem only. That's why the patient has come to your ophthalmologist. So visual complaints. He will tell you, sir, my vision is reduced. Or he will tell you, sir, I am seeing some extra colors. I am seeing some blue. I am seeing some yellow. Or sometimes he will tell you color vision is wiped off. That means color vision I am not able to appreciate. That's not different. But now patient comes in, what he will tell you, sir, I am seeing one object is there. I am seeing everything as double. Next, I am seeing a diminished vision as if I am seeing through a mist, or I am seeing some flickering lights, extraordinary lights or flickerings. Then I see some colored halos around lights. Normally, what now? When you see a flickering light, you have to ask a leading question of migraine. That is what the problem. Seeing halos around lights, you are going to ask a leading question of what? Early stages of angle question glaucoma, primary angle question glaucomas. But now we are talking about the drugs. These are the diseases which can produce this type of symptoms. Misty vision, the problem is because of uveitis, iridocyclitis. But the problem is what now? We are going to ask a leading question, which drug would have consumed? He would have consumed some drugs which can result in uveitis. Maybe the reason for this problem. That we are going to discuss. Now we see here. The patient sees everything yellow color. This yellow color is because of digoxin. What happens now? The digoxin has got some effect on calcium metabolisms and all, so which can lead on to cataract formations. Cataract formations. So naturally you can see everything yellow. But remember, the problem of jaundice also they can have yellow vision. That is different. I am talking about the drugs. Digoxin can produce a yellow vision. Never forget yellow vision. Now, classical history. Van Gogh, a great painter, he was taking digoxin those days, or digitalis components, and his paintings were having more of yellow color because of the side effects of the digoxin. Now here, the patient sees everything blue. Everything blue. When the patient tells you, sir, everything I'm seeing blue, sir, blue. Your answer is, sir, are you taking or have you consumed sildenafil? Sildenafil, what for now? Erectile dysfunctions. What is sildenafil? It is a phosphodiesterase 5 enzyme inhibitor. That is for erectile functions. That's different. Phosphodiesterase 5 for erectile dysfunctions. But in addition to that, this sildenafil can inhibit the phosphodiesterase 6, which is present maximum in your photoreceptors like rods. Naturally, when they're inhibited, what happens now? These rods and all, they're highly sensitized. The rods are highly sensitive for blue color. That is why the patient sees everything blue. But what happens now? Once you can, problem is there, started blue vision, but it subside on its own. After 1 or 2 hours, it subside. That's why important point. It's not alarming. Another patient comes to you, sir, I'm seeing one object is there. I am seeing everything as double. Everything is double. Every single object pays for double. 2 objects for me or 2 images. This is called diplopia. But what's the reason for what the drugs you are supposed to? The common drugs which we have been taking, what? Of course, topiramate, fluoroquinolones, tetracyclines, steroids. These drugs are notorious to produce double vision. What for? Why? The problem is what? These fluoroquinolones, these drugs, they have been producing, or they can produce tendinitis, tendon inflammation of tendons of the ocular muscles, which can restrict movements, which is resulting in double vision. That's what answer for these cases. Now we see, now here is a red tear, red color tinged tear is coming, tear fluid is coming. That means what? Bloody tears, bloody tears. The drug you are supposed to ask for the history of bloody tears is rifampicin. It's an anti-tuberculous drug. Anti-tuberculous drug, rifampicin, can get excreted via tear fluid. That is why they becomes what? Red color. The same thing happens to yellow, that is red urine also, you know that. But rifampicin, okay, one important point of caution for ophthalmologist: when has been taking rifampicin and the fellow has been using soft contact lens, advise them not to use, because the contact lens can get stained. That's why better avoid soft contact lens in a patient who has been taking rifampicin. Now I told you, misty vision or a blurred vision. Why? Because of iritis, inflammation of iris and ciliary body. Why here? Because of these problems, the plasma proteins from the vessels, they can enter your aqueous humor, which is an anterior chamber. So naturally, what now? The misty vision is there. But the most important drug you are supposed to ask the patient is what? Bisphosphonates, classically used for in females osteoporotic cases. Other drugs don't bother. At least a lady has come to you, sir, I'm taking same time, misty vision, sir. Before you had to ask a leading question now: are you taking bisphosphonates? So naturally, once you control, yes, the problem and you stop, it may get reduced. That's different. Then topiramate, anticonvulsant. So topiramate, which can be used for some neurological problems, may produce ciliochoroidal effusions, which can result in anterior chamber shallowness. Like this, anterior chamber shallow can take place. Now we see now here. This is the anterior chamber. See now, the angle is closed. So this is what? Because the lens has come forward. So now in this case, the lens has come forward. That means the anterior chamber it is going up, and you can see the angle is getting close. The reason for the topiramate producing halos around lights, the reason is a raised intraocular pressure because of angle quotient glaucoma. Never forget this. Other drugs, these are all, of course, on black licorice is called adimadram. You might have seen, in some of the advertisements, this has been used. That adimadram mixed with some tea. Then we can have other drugs like ranitidine, which have been commonly used for so many problems, gastric problems. Then clomiphene or clomiphene, you are going to use for what? In females, to have extra ovulations. That's the reason when you have a patient comes and tells you, sir, I am seeing some flickering lights like this, scintillating scotomas like this, different lights scintillating. Be careful. You have to ask a leading question for the intake of clomiphene. And sometimes patient tells you, sir, this object is there, the central part of the object I cannot see. Here also this is called central scotoma. Here you can see, here the central alone not able to see. That means what? The drugs, so many drugs are there which can produce problems in the macula, can result in this. Now, so far, I have told you something about the drugs. I have told you something about the drugs intake or drugs regarding the symptom-wise. Symptom-wise, I have told you some of the drugs. Now, I'll tell you the problems in relation to the structure of eyes, individual parts of the eye, how they are going to have problems. See now, it's called subconjugal hemorrhage. See, subconjugal hemorrhage is there. Whenever you see a spontaneous subconjugal hemorrhage, of course, BP, hypertension, all different. That is different. Diabetes, hypertension, all different. But most important problem, history of intake of drugs like aspirin. Never forget to ask for the history of aspirin, which is commonly used. Then, of course, clopidogrel. These are the drugs, clopidogrel. Understand now, these are the drugs. You have to ask a leading question. When you see a subconjugal hemorrhage in a patient of cardiac patient or something in a patient is there, and you are seeing this subconjugal hemorrhage, think about the problem. He might have been consuming aspirin or clopidogrel or anticoagulant, same thing, heparin, whatever thing is there. Now, in the cornea, I can see some drugs which can produce a picture like this. That's called vortex keratopathy, otherwise called cornea verticillata. Cornea verticillata. These are all deposits only in the cornea. Whereas, remember one point here, there is no visual problems. The vision may not be affected in these cases. But the causes what? When I see examine a person is having cornea verticillata, I have to ask a leading question: are you taking chloroquine, hydroxychloroquines, and amiodarone for cardiac problems, atavacphone for toxoplasma problems? That's why chloroquine, hydroxychloroquine, I asked, no, it's a common exam question again. Normally, even a single dose of chloroquine can induce this problem. Don't think you need a dose related. Whereas amiodarone requires some dose. It has to go above some dose. Then only can produce, amiodarone can produce a change in the cornea. Whereas atavacphone, classically, where now for antitoxoplasma. But this antitoxoplasma, atavacphone, normally used where? In a patient with AIDS. AIDS, toxoplasma, atavacphone is better. Of course, normal person also can give, that is different. But why normal person you are not giving pyrimethamine? Pyrimethamine, a classical drug which has been used for toxoplasma. In a normal person, the pyrimethamine can produce a bone marrow suppression. So naturally, the drug better avoid. It's not always avoided, but better avoid pyrimethamine in toxoplasma of AIDS patients. Chlorpromazine, there's a lorlatil, antipsychotic. Now, these drugs, when you have 5 milligram per day, given for a prolonged period, higher incidence of, but never forget, irreversible corneal deposits. They can have corneal deposits. You can see in the cornea, in the stromal area, deeper stroma. You can see now, chlorpromazine. Drugs you have to ask for is always bilateral. Being a systemic problem, you have to think about bilaterality. Now, the drugs which can produce uveitis. Remember, so far, before I was telling about the symptom-wise. Now, I am telling you that area-wise, the structure-wise. Now, uveitis, iris problems, iritis, inflammations, or ciliary body inflammations, rifabutin. Rifabutin, what now? Is being used for tuberculous drugs. Rifabutin drugs, which induces uveitis, can result in misty vision. And never forget, I will stress the importance of osteoporosis in females. Osteoporosis in females can be treated with bisphosphonates. You expect a patient to come to you. She has been taking bisphosphonates. Sir, I am seeing some misty vision. Be careful. Be careful. The bisphosphonates, you have to ask a leading question. Now, the lens, the cataract, everyone knows about cataract. The lens has got, you know that we have got lens capsule is there, then cortex is there, nucleus. These are the various areas. Now, on the capsule, that is anterior capsule area, some opacities may result. Whenever you see an opacity on the, or opacities in the anterior capsule, think about chlorpromazine intake. Bilateral again, like this. The patient has come to you like the opacity is like this. Ask a leading question: are you taking some drugs? Or you have to ask at least the relatives who are coming with that fellow, who is going to come with these fellows. That's called antipsychotic drugs. So please remember, anterior capsular cataract can be produced by chlorpromazine. Next is what now? Suppose the lens is there, capsule is there. Under the anterior capsule, sometimes there can have opacities. That is called anterior subcapsular opacities. Can occur where? Can occur where means amiodarone, anticholinesterase, like intake of neostigmine, physostigmine, this type of drugs, anticholinesterase, they can produce opacities under the capsule, anterior capsule. Sometimes they can have steroids and chloroquine, they can produce under the posterior capsule, the posterior cortical opacities, or posterior subcapsular, or posterior cortical opacities. So whenever, depending upon the location of the opacities in the lens, you can tell the most probable drug the patient would have consumed. Anterior capsular, I told you chlorpromazine. Subcapsular, amiodarone, anticholinesterase. Then posterior, you got steroids and understand now, chloroquines. Then drugs affecting the retina, classically antimalarials. These called, see now we have a dark area, again a light area, again a dark area. This is called a dark, it's called target. It's called a target sign or target. That means bullseye macular, it's called bullseye maculopathy. Bullseye maculopathy. Bullseye maculopathy. That means what? Whenever you see a person having bullseye macula, be careful. the patient would have consumed chloroquine. But once he has come to you with this classical sign, even if you stop there, it will never reverse. You cannot reverse it. That means what is the idea now? I've shown the dose, the retinotoxicity related total cumulative dose of more than 300 grams. That means what is increased more than 300 grams cumulative dose, total dose. Normally, chloroquine is given for usually for rheumatoid arthritis and all, you know that. So naturally, this drug, when you increase some dose, you have to be careful. That's why, as an ophthalmologist, you must advise whenever a patient is taking chloroquine, if the dose is going above 100 grams cumulative total dose, you advise proper eye examination. Once a bullseye maculopathy developed, it cannot. Whereas before developing that, you have got some test, classically simple test, a field charting. You can do a field charting. Field charting can do. No, macula is what now? You see, the entire retina is going to some outside world. But now the macula is responsible for 10-degree area, 10-degree area. That means what? Within 10, the extended field is different. See, superior 60 degrees, nasal 60 degrees, inferior 70, temporal 100. These extended fields for uniocular fields. Now this fellow is developing a problem. Within 10 degrees, you have to examine. That means what? A patient dose has increased above 100 grams. You try to examine the patient fields mainly for red objects. That means you can find out within 10 degrees some area of non-seeing. That's called scotomas. So within 10 degrees, if I examine the person, small scotomas for red objects, when they develop, better stop the drug. The problem can be reversed. This is what our advice. You have to give advice like this. Otherwise, now you have got what? Optical coherence tomography. OCT is there. Optical coherence tomography, that is different. That also you can do. You can use it to find out the problems, early problems. But it's called, you know the name of the sign? Flying saucer. It's called flying saucer. Flying saucer sign. Flying saucer sign in OCT. It's also a common question for you. What is the flying saucer sign? Can occur in hydroxychloroquine or chloroquine. That we tell in the exams. Other drugs, phenothiazine, used for schizophrenia and all, they can have changes in the retina pigments and all. This is called salt and pepper. Salt and pepper pigment changes in the periphery and posterior pole. It's called posterior, just be the macula and all, the posterior pole is there. Then peripheral part also, this. These are all salt and pepper fundus. Classically occurs in phenothiazines, group of drugs. Fluoropormazine again, apart from lens, apart from cornea, even the retina also they can have atrophy. See now the diffuse atrophy changes. And you see the vessels of the core are also getting problems. The atrophy of the cornea capillaries. Naturally, the vision is affected. So chlorpromazine can, in addition to cornea, in addition to lens, they can have changes in the retina also. Now maculopathies. Again, the macular problems. That's what I told you. Drug-induced maculopathies. Tamoxifen, canthaxanthin, methoxyfluorine. Methoxyfluorine is an anesthetic. Naturally, they can produce changes in the macula. Now, canthaxanthin is an enhance the sun tanning. It's a carotenoid. That fellow can develop a problem. Prolonged application can have these problems. Tamoxifen, you know that. For breast tumors and all, after removal and all, they can give drugs like tamoxifen. They can also induce changes in the macula. You have to ask a leading question of this. Now, classical interferon alpha. Now, interferon alpha, it has been used for even for your interferon alpha can be used for so many tumors also. And they can have a lot of, these are called cotton spots. You see now, cotton spots. These are all called cotton spots. What are cotton spots? If an answer is, it's an ischemic area in the nerve fiber layer, axons. Ischemic infarctions have taken place. The blood supply is cut off. That is why cotton spots have appeared. So interferon alpha, they can develop problems in the patient. That means when you have a cotton spot, one more point, important point, never forget. If you're asked the exams, in a young adult, if you see even one cotton spot in the fundus, never forget to ask for the history of HIV infections. So HIV can produce cotton spots, classical. It's an ischemia again. ischemic only. But the problem is HIV, that's not disease. Whereas here the drug is what now? Interferon alpha. You have to ask for leading questions. Interferon alpha 2B, they are using normally for cases of lymphoid problems. You know, you got YSSN, you know that ocular surface squamous neoplasias or Bowen disease. It's a classical thing. Interferon alpha 2B can be used for these diseases, for the tumors, carcinoma in situ. These are the drugs you are supposed to ask. They can develop retinal changes. Nicotinic acid, they can develop edema of the macula. See now, edema of the macula can take a OCT picture. The edema of the macula is there, cystic spaces, and the FFA fluorescein also they can have. So nicotinic acid, maculopathy. Drugs, classical effect in optic nerve. Never forget ethambutol. Ethambutol, normal dose, what now? They will give 15 milligram per kilogram body weight. You know that. But when the dose is increased above 25 milligram per kg body weight, be careful. Be careful, because there are problems called lipidosis. They can producing lipidosis problems within the nerves, infiltrations. That's why they have a problem of optic nerve problems. Vigabatrin. These are all antibiotics. They can have visual field effects. The contraction, the visual fields can take place. When a patient comes to you, contract the fields, you must ask for the history of vigabatrin. Sometimes patient comes with the nystagmus, the oscillations of the eye, involuntary oscillations of the eye. Be careful. You have to ask a leading question of barbiturates, phenytoin, carbamazepine, tamsulosin. You know, it's an alpha blocker. You know that. Commonly give for prostatic problems. Never forget, this drug can produce what is called floppy iris syndromes. You know, but iris is very floppy, man. So when I do a cataract surgery, naturally we'll have problems. The iris can get easily torn. That's why we have to be very careful. Ask floppy iris there. Think about problem of tamsulosin. The problem is what now? Even when it stops the drug, this floppy iris is there only. It cannot get reversed. That means what? We have to take extreme precautions when you do cataract surgeries for these patients. That's why a careful and detailed case history is important to reveal the patient's or a patient's medication history, so that you know whether to continue or discontinue the drugs. Is the most important point. That's why you should know some of the side effects of the systemic drugs. A patient that comes with a symptom, or when you examine, you got some signs. So always ask for history of intake of drugs. Never forget, otherwise you'll be missing the problems. Hope you have understood something. Thank you very much. And